Our next speaker is Professor Channa Ranasinghe. Professor Channa Ranasinghe is a professor in pharmacology and a specialist physician in the Faculty of Medicine, University of Kelaniya. He'll be talking on what's new in the treatment of bronchial asthma. Over to you.
Thank you very much. I'd like to thank the President and the Council for inviting me to speak. I'm very happy to be here physically. So, what's new in the management of asthma? Well, we often get these headings thrown in at conference, what's new in this, what's new in that, and really I'm happy to say there really is something very important that I would like a general audience to know about what is new in bronchial asthma. This is a picture of the eruption of Mount Vesuvius. The last major eruption was in the mid-1950s. But the better known eruption took place in AD 79 when the cities of Herculaneum and Pompeii were covered in lava and ash. And this is Pliny the Younger writing about his uncle, not his father, Pliny the Elder, who was the admiral of the Roman fleet, and he took his ships to the coast to try and rescue people who were fleeing the eruption. He was also an asthmatic, and he died in that rescue effort. And this is Pliny writing about his uncle. He says, leaning on two servants, he brought himself upright and immediately collapsed again. I suppose because he was affected by the dense fog that obstructed his airways that were weak in nature, narrow, and subject to inflammation. So when we talk about what's new in asthma, we must understand that 2,000 years ago, they had a very strong grip on what was going on. So he supposes that he was exposed to the dense fog. So that was an environmental trigger, which we agree with. Whether he knew that ventral defects are obstructive or restrictive, I suspect he did not, but he said this was an airway problem. He said that he recognized that there was a difference between his own airways and his uncle's airways, because his uncle was prone to asthma and that they were weak in nature. And then probably the most prescient thing he says is that the airways were narrow and subject to inflammation. And what better metaphor for inflammation can there be than the eruption of a volcano? Now, before we talk about what's new, we must re-emphasize that the cornerstone of managing asthma is the control of inflammation using inhaled corticosteroids. And evidence like this goes towards our thinking. So on the y-axis, you have improving lung function, and on the x-axis, time, 2 years, and then a bar where there's a third year added on here. So they took patients who've got mild asthma, and they randomized them to either terbutaline, which is a short-acting beta-2 agonist, given regularly. There was some improvement in their lung function over 2 years. They randomized the others to an inhaled steroid, budesonide, and those two arms improved, and improved more than the beta-2 agonist treatment group at the end of 2 years. So clearly, controlling inflammation was beneficial. But then they did what was really interesting, and they switched things around. So the patients who were on budesonide either continued their budesonide, the inhaled steroid, and maintained the improvement in their lung function over a third year, or they were switched to placebo, in which case they lost the benefits of their inhaled steroid. Or most interestingly, the people on the short-acting beta-2 agonist were switched to inhaled steroid for a year. Their lung function improved, but it never caught up with the people who'd been on it all the time. There was this gap. And what we conclude from that is that if you don't start the inhaled steroids early and control airway inflammation early, you lose lung function, which is difficult to catch up when you start later. So this is what we do now. We start with a short-acting beta-2 agonist, SOS as needed. We then move on to regular inhaled steroids. We add in a long-acting beta-2 agonist if they're not controlled. We add in then all the other treatments we have available to us, theophylline, anticholinergics, oral drugs, to try and prevent us moving to step 5, where we have to rely on regular oral steroids with the complications that engenders. And all that is very well evidence-based, but interestingly, it's from step 1 to step 2 that is not well validated in the research. When do you go from what we did up to now, use SOS beta-2 agonists to control intermittent mild symptoms, and when did we move on to regular inhaled steroids? Some physicians will say, well, if you've got symptoms once a month, you ought to be on inhaled steroids. Others would say, no, it has to be much more frequent, maybe once a week, then you deserve, in inverted commas, to be on an inhaled steroid. And interestingly, what the advances, what is new now, is that we have solved that problem, even though we have not answered that particular question. So, what may surprise you about what is new in the management of bronchial asthma is that it is all to do with beta-2 agonists rather than any other treatments, newer treatments. When we think about beta-2 agonists, we are familiar with, let us take the difference between inhaled salbutamol and oral salbutamol. Both are short-acting. The inhaled salbutamol works very quickly. We have, in contrast, longer-acting beta-2 agonists. We have long-acting beta-2 agonists that are dosed twice a day, formoterol and salmeterol, and now we have the ultra-long-acting once-a-day beta-2 agonists, the vilanterols and the indacaterols, and there are others. What we tend to overlook, though, is that their speed of onset is not uniform. So salmeterol and the ultra-long-acting beta-2 agonists work quickly, but not immediately. Whereas formoterol, in the same class, has an onset of action as fast as salbutamol. I don't know if there are asthmatics in the audience. I certainly am one. And when you need a puff of short-acting relief, you know that by the time you've taken your inhaler and you've put it back down on the table, you are already starting to feel some relief. Salmeterol, for instance, can take up to 30 seconds to give you that relief. Now, that may not seem a lot, but when you have symptoms, that is a rather challenging time. What really promoted this change of practice that I'm going to come to talk about is our better understanding of so-called mild asthma. Inhaled short-acting beta agonists, salbutamol, terbutaline, have been our first-line treatment for over 50 years. This dates to a time when we thought of the pathophysiology of asthma largely being mediated through airway bronchoconstriction of smooth muscle, which salbutamol-like drugs are very effective at reversing. The patient gets rapid relief from their symptoms, as I indicated a moment ago, and the patient commonly believes, well, my reliever gives me control over my asthma, and they go on to think, well, why do I need anything else? So let's just briefly review the pathophysiology of asthma. On your left-hand side, you have a normal airway with a thin layer of smooth muscle and a small area of bronchial mucosa acting as a sleeve around a nice large airway. With repeated episodes of bronchoconstriction, the smooth muscle hypertrophies, like your biceps when you go to the gym, and the smooth muscle becomes hypertrophied, and constricting. With repeated episodes of inflammation, the mucosa becomes inflamed and thickened, and that results in a narrowed airway. And you can understand that this is an illness of impeded airway conductance. If we look at this histology slide under high power, you can see that the airway is very folded because of the bronchial smooth muscle constriction. And you can see that the airway, the airway mucosa is thickened, and darkly staining nuclei of lymphocytes, largely eosinophils, predominate, reflecting the levels of airway mucosal inflammation. Now, when we look more closely at what we would call mild asthma, it is really not quite as innocent as that tag describes. Patients with so-called mild asthma are at risk of serious health problems. About a third of adults who present with acute attacks of asthma have previously been labeled as mild asthmatics. 16% of patients who have near fatal asthma, which largely means admitted to the ICU, have mild asthma. So mild asthma is not really mild because 16% of people end up in the ICU. And about a fifth of patients who die of asthma, if you look back at their asthma treatment and their classifications, they would have been called mild asthma. So mild asthma is really anything but mild. The background to these changes are twofold. One is in vitro evidence of the problems with regular and frequent use of short-acting beta-2 agonists. We know that there's beta receptor downregulation, so that it is less effective. There's decreased response, there's tachyphylaxis, and there's rebound hyperresponsiveness. So the next time you're exposed to a trigger, you get a greater degree of bronchoconstriction. So this is in the test tube. We also know from epidemiological evidence that higher use of short-acting beta antagonists is associated with adverse clinical outcomes. If you are dispensed more than 3 canisters of salbutamol a year, you are at higher risk of needing to attend an emergency department with an acute episode of asthma. If you are dispensed more than 12 canisters a month, that's 1 a month, your risk of death is increased. So these are not benign drugs used for benign illnesses, but they have significant morbidity and mortality attached to them. What is the clinical trial evidence for this? The first hint of a problem here really came in the early 2000s with the so-called SMART study, where about 12,000 patients in general practice were randomized to continue their routine treatment or have added in salmeterol, the long-acting beta-2 agonist. This study was stopped early. There was a similar dropout in each treatment group, and asthma-related deaths were 4.4 times as likely in the group who were given salmeterol as the group who received the placebo. That translated as 1 death on salmeterol for every 700 patients given salmeterol for 1 year, which, given the large number of prescriptions of salmeterol, is a very significant problem. But the study was very problematic and difficult to fully interpret because randomization to the salmeterol was not stratified in any way. So there were not equal numbers of patients given salmeterol on inhaled steroids and not on inhaled steroids. And in fact, when they went back to look at the data, they were unable to recover whether patients were on inhaled steroids or not in any individual case. And so the consensus grew that probably those increased deaths arose from patients who were given long-acting beta-2 agonist without the protection of an inhaled steroid. It wasn't proven, but the question was then asked. So what is the evidence for the change that I'm going to describe to you now? This is the kind of thing. Again, a group of some 600 patients with physician-diagnosed asthma were treated for a year. One group got as required salbutamol to take when they needed it, what we would previously to now have done for our mild asthmatics. One group got a fixed regular dose of inhaled steroid and were invited to use their salbutamol as much as they wanted. And in the third group, they were given a fixed dose combination of an inhaled steroid budesonide and the long-acting beta-2 agonist formoterol, which I'll remind you acts as fast as salbutamol, and told use it as they need. And in numbers of interpretations of the data, this was the clear message that came out. If you're on the albuterol, which is the American term for salbutamol, let me see if I get that, yeah, you had more exacerbations than if you were on either regular inhaled steroid alone with backup salbutamol or the fixed combination that used SOS. Now, there's no difference in those two groups, but those two groups were clearly an improvement on single-agent short-acting beta-2 agonists. And the same was shown in terms of time to first exacerbation. This is the deteriorating condition in patients who are on single-agent short-acting beta-2 agonist. These two groups are difficult to distinguish between, but they show a longer time to first exacerbation. So clearly, there's a benefit from starting the inhaled steroid early, and you can do that in two ways. You can give them regular inhaled steroid and say, take your salbutamol SOS, or you can give them a fixed dose combination and say, use this as you need it. If we think about that for a moment, let me just go back before I show this. If we think about that for a moment, what you're asking, you're giving the patient a choice from this study to say, you have very mild intermittent symptoms, take an inhaled steroid every day, whether you feel you have symptoms or not, and when you get the symptoms, take the salbutamol. Or you say, here's a fixed dose combination, it has two drugs in it, use both together in a single device when you have your symptoms. And that clearly is the better way to improve compliance with the inhaled steroid component. So, GINA, the Global Initiative on Asthma, in 2019 made a landmark change in their asthma management. And the important point is that they did this for safety. And they no longer recommend short-acting beta-2 agonists alone in treatment at step 1. To summarize, short-acting beta agonists only increase the risk of severe exacerbations, while adding in an inhaled steroid significantly reduces the risk. What do they suggest? All adults and adolescents with asthma should receive an inhaled corticosteroid containing reliever medication to reduce the risks of serious exacerbation. That is to say, if they're taking a beta-2 agonist, they should take an inhaled steroid along with it. So this is now what those 5 steps of asthma management look like. 2, 3, 4, 5 are largely unchanged. But at step 1, what do they recommend? The preferred controller is as needed low-dose inhaled corticosteroids and formoterol, not even salbutamol. Why? Because they both act very rapidly, but formoterol, excuse me, has a 10 to 12 hour duration of action. So you will not need as so much drug as if you took a combination of inhaled steroid and salbutamol. The other option, and it is less preferred as I've indicated earlier, is to take regular low-dose inhaled steroid with a short-acting beta agonist, both together when you need it. But that is, of course, impractical to expect patients to do on a regular basis and use regular inhaled steroid. So whenever this game-changing information is given to different audiences, general practitioners, physicians, respiratory physicians, the question that we are most commonly asked is, how much can we use? How often can we use this so-called drug? And the two issues to think about there are the toxicity really associated with increased amounts of beta-2 agonist and any possible toxicity of an increased delivery of inhaled steroid. And the symptoms from the first one are well known to us, and that will limit patient use. But the risks of a little bit extra inhaled steroid are almost zero, are certainly negligible. So if you're using a dry powder inhaler, for instance, a budesonide formoterol combination, you can use up to about 12 inhalations a day if you can tolerate the beta-2 agonist component of that. If you're using a metered dose inhaler, which has better lung delivery, something like 6 inhalations of a beclomethasone formoterol combination can be accepted. But really the important point here is to remember that if formoterol and inhaled steroid are an acceptable and now preferred and recommended combination, salmeterol inhaled steroid, often paired with fluticasone, is not a suitable drug to use as a reliever for mild symptoms. It can be used later on as a preventer at step 2, at step 3, step 4, and so on. But if you're going to give someone a combination of salmeterol and fluticasone, you also have to give them a combination of inhaled steroid and formoterol to use as their reliever medication. So that's 2 different inhalers. Whereas if you're going to give them formoterol inhaled steroid of whatever stripe, that can be their reliever medication. And if they need to step up for regular medication for prophylaxis, they can use the same inhaler. So you can be on maintenance formoterol inhaled steroid, and you can use the same inhaler, SOS, when you get symptoms in the middle of the night during your working day. That's all I'm going to talk about asthma in a sense there, but no lecture at the moment is complete without some reference to the coronavirus. And what is the status of coronavirus infection and asthma? At the start of this pandemic, we were very concerned about asthmatic patients. The major morbidity of this illness is respiratory disease, and it is usually the cause of the mortality associated with disease. And we were very concerned that patients with chronic lung disease would suffer increased mortality. And we were pleasantly surprised, I would say, to see that the early data, and now confirmed, shows that there was no increased susceptibility or severity of the disease if the asthma was reasonably well controlled. What about deaths? Are people with asthma at increased risk of COVID-19 related death if they get infected? Again, if they're reasonably controlled, I think well controlled is a strong term to use. If they're reasonably controlled, there is no overall increase. Whereas if their asthma is unstable and severe, to the extent that they recently had a short course of oral steroids, then they do have an increased mortality. So if overall the situation was not worse, what surprised us even more was to find that, in fact, patients with asthma were significantly underrepresented in COVID admissions and COVID deaths. Underrepresented. And the thought immediately turned to whether there was some protective agent, and naturally we focused on the steroid component, inhaled steroids. Are they in some way protective in COVID-19? In one study, sorry, let me move this out, it's distracting. In one study looking at subgroup analysis retrospectively, they showed lower mortality in asthmatics over 50 who were taking inhaled steroids than in patients who didn't have chronic lung disease. So a study was set up in rural Oxfordshire to look at inhaled budesonide in the treatment of early COVID-19. This is an open label, randomized controlled trial in general practice. Patients within 7 days of the onset of mild symptoms of COVID-19 were asked to continue their routine treatment and randomized either to no additional treatment or dry powder inhaled steroid, what I would call a moderate dose of inhaled steroid. They managed to randomize 146 patients with a mean age of 45 years before the conditions of the epidemic changed and they could no longer recruit patients. So they did not finish, they were not able to complete their study in terms of sample size as they set out. Nevertheless, the endpoint, which was set as the need to go and see your GP or to go and be seen in hospital because you were getting worse, was analyzed, and in the inhaled steroid, the budesonide group, 1 out of 69, in the usual care group, 10 out of 70, p-value that you see, and very interesting and very persuasively, a number needed to treat of only 8. That is, say, for 8 patients in this situation that you put onto inhaled steroid, one of those patients was prevented from having to go and see the GP or be seen at hospital. So, on the face of it, very persuasive evidence when a single non-placebo controlled trial. So, if I may just share this with you, our group at Ragama have set up a trial looking at inhaled beclomethasone in the early treatment of COVID-19, and this will be the first placebo-controlled randomized protocol. We are looking to see whether inhaled dry powder beclomethasone is effective at reducing disease progression of asymptomatic or mild moderate patients to severe disease. We are doing this at Kandana District Hospital, which is a residential treatment center. Patients over 18 with asymptomatic or mild or moderate COVID-19 within the first 7 days of symptoms with a positive virological test. The patients are randomized, in addition to their usual care, to either beclomethasone or a matching dry powder placebo in a double-blind fashion. And we set out to look at 380 patients, 190 in each ground. What was our primary endpoint? Progression of disease severity as defined by a drop in oxygen saturation, as well as any one of the following: needing regular oxygen treatment, starting dexamethasone, or needing to transfer them, in this case to Ragama, for higher healthcare treatment facilities. We collected the data, daily interviews from each patient, measured temperature, oxygen saturations, and there were some healthcare, lifestyle kind of questions. We enrolled up to the 1st of November. We've recruited the number we need, and we have a few dozen patients still finishing up their follow-up. So hopefully this will add something to our thinking. So what should we do in the meantime? We must advise our patients to take their prescribed asthma medications, particularly their inhaled steroid. We must make sure that all patients have a written asthma plan. We want to reduce the use of nebulizers because of the risk of propagation of the virus. And when we do spirometry, which we do under more selected basis, we now ask for some kind of antigen test before they come up and use the devices. My last slide is an update on the use of montelukast, the leukotriene receptor antagonist. Since March of 2020, these class of drugs, of which montelukast is the most popular by a mile, carries a black box warning about neuropsychiatric problems, suicidal ideation in adults, and nightmares and behavioral problems in children. Montelukast is used more, prescribed more in the US than inhaled corticosteroids because probably in a pediatric population, there's a certain degree of steroid phobia still among adults. So before prescribing it, we must think a little bit about that. So my last slide, and I'm sorry I've just run over slightly, is to remind you what we are doing now in the step one. We're no longer ever, please, going to use salbutamol on its own. We're going to use a combination of a long-acting, quick in onset inhaled beta-2 agonist, such as formoterol, combined with an inhaled steroid, and ask them to use that as their replacement for their inhaled salbutamol alone. Thank you very much.
Thank you, sir, for that brilliant lecture. And I call upon Dr. Dhanapala to present the token of appreciation on behalf of Sri Lanka College of Internal Medicine.
Attention please. The lunch will be served at Ivory Room, Ebony, room near Atrium Lobby for the delegates.